Hello and welcome to Clinical Society meeting. Today in the Clinical Society meeting, there are two presentations. The first presentation is from Department of Radiodiagnosis and Imaging, and it will be moderated by Dr. Ishan Kumar. And the second presentation is from Department of Radiotherapy, and it will be moderated by Professor UP Shahi. I request the moderator for the first presentation to initiate it. Over to Dr. Ishan.
Thank you, sir. Without any delay, I would like to start my first presentation. It will be done by SR Vritika Bhardwaj. Thank you.
Good morning, everyone. I'm Ritika Bhardwaj, SR from Department of Radiology, and we are going to present on uterine artery embolization, non-surgical management in selected pathologies. The main aim of our presentation is to demonstrate the management option of uterine artery embolization in various pathologies as a novel modality for our institution, particularly in cases where the patient is young and wants to preserve fertility and wants to avoid the risk of major surgery as well as scar. We'll be depicting the procedure in three main indications of endovascular uterine artery embolization. However, uterine artery embolization is just a management option presented with the patient along with surgical options rather than an alternative. The first case is that of a 36-year-old female with secondary infertility, and she was referred to our intervention radiology unit from Department of Obstetrics and Gynecology for assessment and intervention for uterine fibroid. The patient was referred to our department after appropriate counseling as well as clinical and laboratory parameters assessment. The history of present illness included heaviness in lower abdomen for approximately 1 year and inability to conceive for 5 years. Pregnancy, active or recent infection, any gynecological malignancy were ruled out clinically and or radiologically. There was no history of severe contrast allergy. There was no history of prior pelvic surgery or radiation therapy. Ultrasonography was done as the initial screening modality, which revealed a well-defined, homogeneously hypoechoic mass lesion measuring approximately 9 into 12 into 13 centimeter, arising from the myometrium of uterine fundus. On color Doppler examination, the lesion showed multiple areas of increased vascularity, as we can see over here. Contrast-enhanced MRI was done next for uterine fibroid mapping. The coronal turboinversion recovery magnitude image showed a well-defined, homogeneously hyperintense mass lesion arising from the fundus of uterine myometrium as well as involving serosa. The lesion is causing indentation as well as compression of endometrium towards left side as well as indentation on the fundus of urinary bladder. Few flow voids can be seen over here, which indicates the feeder vessels. The similar findings correspond on sagittal T2 weighted imaging, as we can see over here. Contrast study was done, and post-contrast axial as well as sagittal image showed avid contrast uptake by the fibroid. The exact size was measuring approximately 9.6 into 15.2 into 13.9 centimeter. So overall, we have a case of 36-year-old female with intramural subserosal fibroid measuring approximately 9 into 15 into 13 centimeter. We showed avid contrast enhancement on contrast enhanced MRI. So clinically and radiologically, she is a good candidate for uterine fibroid embolization. The patient was also presented the option of surgical management. However, she went ahead for uterine artery embolization. So the case was planned. A proper informed consent was taken. Laboratory parameters like including complete blood count, renal function test, and coagulopathy and coagulation parameters was ensured to be within normal limit. Antibiotic coverage prophylactically was given in the form of cefazolin intravenously 1 hour before the procedure, and the procedure was done at a moderate conscious sedation. So, vascular access was obtained into right common femoral artery using Seldinger technique, and a diagnostic angiogram was taken. On diagnostic angiogram, the principal arterial feeder was seen arising from left uterine artery. So, further, the catheterization was done into right external femoral artery, right common femoral artery, the contralateral, that is left common femoral artery, left internal iliac artery into its anterior division. While the catheter was there in the left, in the anterior division of left internal iliac artery, a microcatheter was coaxially introduced into the catheter till the level of uterine artery. The arcuate branch of left uterine artery was catheterized, and again an angiogram was taken. Here, the angiogram reveals prominent arterial supply from left uterine artery, mainly arcuate branch, and they are going all over. Fibroid as well, outlining the same, as we can see over here. The vessels are outlining the fibroid. Embolization was planned to be done by polyvinyl alcohol particles mixed with contrast, which are basically permanent particulate embolic agents. After having super selectively cannulated the arcuate branch of left uterine artery, the polyvinyl alcohol particle mixed with contrast was injected in pulses for flow-directed embolization, as we can see over here. After embolization, there was sluggish forward flow seen in arcuate branch of right uterine artery, as well as the prominent arterial supply that was opacified previously are not opacified right now, indicating of successful embolization and embolization endpoint. In immediate post-procedural period, the patient experienced post-embolization syndrome in the form of pain and fever, which were managed conservatively and subsided after 24-hour post-procedure. There was no evidence of infection, respiratory distress, or any other complication noted in post-procedural observation period. Follow-up was done at 1 month as well as 3 months, and the patient had relief in lower abdomen heaviness. The pre-procedural volume was 1043 cubic centimeter, while the same at 3 months of follow-up was 288 cubic centimeter, which indicates the reduction in size is more than 70%, and it was significant. We did a transvaginal ultrasonography at 3 months of follow-up, which revealed this heterogeneously hypoechoic lesion, which showed significant reduction in the size as well as increased heterogeneity. The next case is that of a 27-year-old female presenting with secondary postpartum hemorrhage. She was referred to our interventional radiology unit from Department of Obstetrics and Gynecology for evaluation and intervention of the underlying uterine arteriovenous malformation after appropriate clinical and laboratory parameters assessment. The patient was hemodynamically stable while she was referred to our department and desired preservation of fertility. Other entities which might cause postpartum hemorrhage, like retained product of conception, placenta accreta, any active or recent infection, any gynecological malignancies, were ruled out clinically and or radiologically. There was no history of severe contrast allergy, prior pelvic surgery, or radiation therapy. Transvaginal ultrasonography was done as the initial screening imaging modality, which revealed multiple anechoic tubular cystic spaces involving uterine myometrium of the fundus. The visualized part of endometrium was clear. Further, color Doppler examination was done, which revealed the previously anechoic spaces showing increased vascularity. Spectral Doppler was done, and the waveform was that of high flow and low resistant type, consistent with the diagnosis of arteriovenous malformation. CT angiography of pelvis was done in order to delineate the exact extent of the lesion, to determine the arterial feeders, nidus, as well as early draining veins, as well as to determine the exact approach for catheterization. These two are the axial contrast enhanced CT angiographic images in arterial phase. And here we can see a serpiginous collection of vessels, the attenuation of which is similar to that of adjacent arteries. On the next image, we can see some of the prominent right parametrial veins, as we can see over here, which are getting opacified, partially opacified in the arterial phase only, indicative of early draining veins. This is a volume render 3D reconstructed image showing enlarged tortuous uterine artery, as we can see over here, going all the way till the nidus. We can also appreciate some of the right parametrial veins However, they are not very well appreciated on reconstructed images. Again, the patient was a good candidate for uterine artery embolization given the diagnosis of uterine arteriovenous malformation. However, again, she was presented with the surgical option, and since she desired the preservation of her fertility, is a young patient, she went ahead for uterine artery embolization. After having taken informed consent, ensuring that the laboratory parameters including complete blood count, renal function test, coagulation parameters were a normal limit, giving antibiotic prophylaxis in the form of cefazolin 1 hour before the procedure. The procedure was done under moderate conscious sedation. Again, similarly in this case also, the right common femoral artery was, vascular access was obtained into right common femoral artery, and an angiogram was taken to determine the arterial feeders, nidus, as well as draining veins. The diagnostic angiography revealed that the main arterial feeder was from right uterine artery, which we can see as enlarged tortuous vessels over here. The nidus was seen as a collection of an area of multiple serpiginous thin vessels, and further they were draining into right parametrial veins, which showed early opacification. So after having done diagnostic angiography, catheter was introduced into right common femoral artery, right internal iliac artery, then its anterior division. After having the catheter in anterior division of right common femoral artery, microcatheter was coaxially introduced, and superselective catheterization of right uterine artery was done, supplying the nidus. Here we can see the SIMS catheter in right uterine artery over here. We cannot exactly appreciate the microcatheter because of contrast opacification. Again, the exact delineation of arterial feeders, nidus, and early draining veins was appreciated just before the procedure for embolization. So in this case, gel foam was used as embolizing agent, which is sterile compressed sponge and are temporary embolic agents. These are water insoluble hemostatic device prepared from purified skin gelatin. Scraping of gel foam is done, and it is thoroughly mixed with contrast just before embolization. So after having done superselective catheterization of right uterine artery, gel foam was injected into the arterial feeder. And here we can see that there is stasis at the level of nidus. And even by the end of embolization, the early draining veins that were opacified earlier are not opacified now, indicative of successful embolization. And the stasis indicates embolization endpoint. In post-procedural follow-up, no further episode of vaginal bleeding was noted, and the patient was discharged 2 days later. Improvement in hemoglobin level was there after the procedure. The pre-procedure hemoglobin level was 8.2 gram per deciliter, and 24 hours post-procedure, it was 9.5 gram per deciliter. There was no intra or post-procedural complication noted. No fresh complaint or rebleed was reported by the patient at 2 weeks of follow-up. After 2 weeks of follow-up, we went ahead and did a CT angiography of pelvis to compare with the previous scan, and there is significant reduction in the size of the nidus. The early draining veins were not seen over here. However, some of the prominent tortuous proximal part of uterine artery, right uterine artery, we are seeing. Next case is that of a 25 years female with pervaginal bleeding post-dilatation and curettage. She was referred to our intervention radiology unit from Department of Obstetrics and Gynecology after appropriate clinical and biochemical evaluation. The patient was having pervaginal bleed for 3 days and was hemodynamically stable. Pregnancy, active or recent infection, any gynecological malignancy were ruled out clinically and or radiologically. There was no history of severe contrast allergy. No history of prior pelvic surgery or radiation therapy was there. Transvaginal ultrasonography was again done as an initial screening modality, which revealed a well-defined anechoic rounded lesion, which showed in the uterine fundus region, which showed yin-yang type of color flow on color Doppler imaging. We went ahead and did a CT angiography of pelvis, which revealed a well-defined saccular outpouching, which shows contrast opacification with neck adjacent to the right uterine artery, suggestive of pseudoaneurysm. Again, the patient was presented with the option of surgical management. And since she wanted to retain her fertility, as well as she was a young patient, she went ahead for uterine artery embolization. After taking informed consent, ensuring that the laboratory parameters, including complete blood count, renal function test, and coagulation parameters were within the normal limit, the prophylactic antibiotic coverage was given in the form of intravenous cefazolin 1 hour before the procedure. The procedure was done under moderate conscious sedation. And after having established access into the right common femoral artery by Seldinger technique, a diagnostic angiogram was done to delineate the exact supply of the pseudoaneurysm. On diagnostic angiography, it revealed that the pseudoaneurysm was arising from the arcuate branch of right uterine artery, as we can see over here. And this is the contrast-filled outpouching, suggestive of pseudoaneurysm. After having done diagnostic angiography, we went ahead for catheterization of right common femoral artery, right internal iliac artery, the anterior branch of right internal iliac artery. While the catheter was in the anterior division of right internal iliac artery, we introduced a microcatheter coaxially till the level of just proximal to the level of pseudoaneurysm. And again, an angiogram was taken. So this is the catheter along with microcatheter, just proximal to the pseudoaneurysm neck. Here, the pseudoaneurysm can be appreciated well with a small segment of uterine artery proximal to it. Since this was a case of uterine artery pseudoaneurysm, the embolization coil was the preferred embolic agents. These are basically permanent embolic agent made of loops of stainless steel wire with thrombogenic synthetic fibers, as we can see over here. After having selectively catheterized the right uterine artery, the microcatheter was advanced distal to the neck of pseudoaneurysm, and a 2x2 Hilal coil was deployed. Again, the microcatheter was retracted proximal to the neck of pseudoaneurysm, and another 2x2 Hilal coil was deployed, thus sandwiching the neck of pseudoaneurysm. And in this image, we can appreciate that the previously opacified pseudoaneurysm is not opacified right now, indicative of successful embolization. In post-procedural follow-up period, there was no further episode of vaginal bleeding noted, and the patient was discharged 24 hours later. There was marginal improvement in hemoglobin level 24 hours after the procedure. No intra-post-procedural complication was noted. No re-bleed was reported by the patient at 1 week and 1 month of follow-up. So predominantly, the outcome was the follow-up was done clinically, and the patient experienced improvement in the symptoms. A follow-up CT angiography was done at 1 month of follow-up, and we can see the metallic artifacts from coil over here. And the contrast-filled outpouching that was seen previously is not seen in this case. For discussion, I would like to request Dr. Ishan Kumar, sir, Associate Professor from our department.
Thank you, Ritika. So in this presentation, we want to discuss the various indications of uterine artery embolization. So there are two primary indications of embolizing this uterine artery. First is bleeding, either postpartum bleeding in the form of post-DNC or post-intervention uterine AVM or pseudoaneurysm formation. If there is any active bleed in traumatic cases, if some trials have used UA in dysfunctional uterine bleeding or even in endometriosis with variable results, and then postpartum hemorrhage, even if we cannot delineate any active source of bleeding, some researchers, some intervention radiologists have tried empirically embolizing this uterine artery. So in these cases, in AVM, pseudoaneurysms, UAE, uterine artery embolization, forms the first line of treatment because it preserves the uterus, and more often than not, the patient is discharged within the 2 days of the procedures. Second indications is fibroid embolization. Now, there are various treatment options in fibroid. The indication of embolization, the embolization of the uterine fibroid embolization is heavy menstrual bleeds, pelvic pressure or pain symptoms, urinary symptoms if there is compression over the ureters or bladder leading to hydronephrosis or various urinary symptoms. Sometimes if there is large vascular fibroid, preoperative embolization is done to reduce the bleeding while operating. And if the patient, most importantly, if the patient wants to retain the uterus. Contraindication of this procedure is pelvic infection and pregnancy. Then there are relative contraindications such as coagulopathy. Contraindications of contrast use is severe allergy to the contrast, or there is renal insufficiency. So what is the complication of uterine artery embolization? In 5% of cases, severe complications such as fibroid passage is noted. So it is characterized by severe menstrual cramping, heavy bleed, and tissue passage, especially in submucosal and degenerated fibroids. The tissue passage occurs through vaginal discharge. So sometimes it manifests chronically, so which leads to persistent vaginal discharge 1 to 6 months after procedure.
Ishan,
Yes.
sorry to interrupt you here. I think the time for presentation is over. So,
Okay. So I'll just move on to.
Yes, you just in 30 seconds you complete it.
Okay. So so as we already discussed that various studies show that the inactive uterine artery bleed or uterine AVM, this is the procedure of choice. This is the trial in which out of 1917 patients had a successful resolution of the AVM. And then again in PPH, 90% of the success was obtained through the UAE. Regarding fibroid, this is the largest study. This is fibroid registered study sponsored by SIR in 2,112 patients. So 87% has significant improvement in the symptoms, and while 6% needed some added hormonal therapy, or 2% patient needed additional hysterectomy. And so there are no definite recommendation whether to do myomectomy or hysterectomy or UAE. So this is my last slide. So there are two main recommendations, one from ACOG and one from NICE UK, National Institute of Health. So ACOG says uterine artery embolization is recommended for women with symptomatic fibroid who wish to keep their uterus, but they should be counseled about the limited data on reproductive outcomes. Again, NICE similarly says that the counseling of the patient is very important, and patient has to be counseled, especially those who are contemplating pregnancy in next 2 years, that the data is limited and there are variable results, and final decision lies with the patient and in consultation with the radiologist and gynecologist. So during the consent process, patient should be informed. Thank you. I think I'll just have a brief comment from the referring clinician, Dr. Shikha Sachan, ma'am.
Okay. Dr. Ishan,
yes,
when you talk about the contraindications, so in the relative contraindication, if the patient is want to conceive, so I think the myomectomy should be the preferred choice in comparison to the uterine artery embolization.
There is thus the data comparing myomectomy and uterine fibroid is understudied, and there are various trials. But one of the study has proven that the myomectomy is slightly better in terms of if patient is contemplating pregnancy within 2 years of the procedure. However, given that the hospital stay is less, patient should be given option of uterine artery embolization. But I think one of the gynecologist, Dr. Shikha ma'am, can.
But I think Ishan, in all the three cases which you presented, you emphasized that patient want to conceive, and that's why you chosen the option of uterine artery embolization. I think that message is wrongly conveyed here, because it is a relative contraindication if you go through the literature.
I would like to answer this, Ishan. I would like to answer this, Ishan.
Yes.
Sir, actually, in surgical for surgery also, there's such a large fibroid. You might need hysterectomy in the setting also. Notwithstanding all the precaution taken and everything, even for arteriovenous malformation, yeah, hysterectomy can be a on-table procedure which could be done. So, not taking the new techniques when thinking that fertility actually is not a, this is the procedure which actually avoids the surgery, reduces the size of the fibroid, and also reduces the size of AVM. So,
No,
fertility.
Dr. Shikha, I am specifically asking myomectomy versus the uterine artery embolization. I am not asking hysterectomy. I am asking myomectomy.
That's what I'm telling, sir. Myomectomy for such a huge fibroid can sometimes result in hysterectomy also, can sometimes result in breach of the endometrial cavity also. This
Okay.
patient, which I had referred to Dr. Ishan, was already 35 years old, sir. She had been investigated for all aspect of fertility, and when no other factor was found, she wanted a treatment for her fibroid. Such a big fibroid can have complications per op also. That's what I'm saying. So this was a newer therapy we offered to her. And that is what, but this per se is not going to cause her fertility problem as such. If you are thinking that it is going to reduce her follicles or any such thing as such.
But
Aberrant embolization.
do you have the
Aberrant
evidence?
embolization can be a problem.
Do you have the
Sir?
evidence which is favoring the uterine artery embolization in the fertility preservation over the myomectomy?
So this is a newer technique. Already the data is limited, as already told by Ishan. There's only one paper which supports the other things, and this needs to be studied definitely.
Yes. Okay.
There are papers in support of both the
Yes.
procedures.
Yeah. Okay. So we have the limited data because I think it's a relative contraindication. So I request Professor Ajay Khanna, sir. Sir, please unmute and give your comments.
Good morning, everyone.
One second.
I just wanted to know that such a large fibroid which is there, and that too it is a subserous and it is not involving the uterine cavity. I think myomectomy should have been a better choice rather than going for that. But if you are doing it for the purpose of that, it is a very vascular fibroid is there and you want to reduce the vascularity of that and then going for the myomectomy, that is acceptable.
So the fibroid was also intramural. So the fibroid was also intramural. It was distorting the endometrial cavity, as shown by Dr. Ishan in the earlier pictures also, sir.
But
It
I
was
think
not only
MRI, we could see a very good uterine cavity here. It was,
yes,
uterine cavity was quite intact in this. The
But,
MRI
sir,
which has been shown.
uterine cavity in the fibroid will be definitely intact. It was only distorting it, but it was having a large intramural component also. That's what I'm trying to signify. Subserosal fibroid, obviously surgery will be a better thing, but this was a big fibroid which had quite a big intramural component, and so the cavity was distorted.
Are you not contemplating that you are going for the surgery further after the uterine embolization?
No, that was an option which was given to the patient, that she might need another surgery if needed, but the fibroid is reduced quite considerably. She might not need the next surgery before going for other fertility options, sir.
So most importantly, the patient was counseled about both the procedures and she wanted the non-surgical option.
Okay, I request Professor Ashish Verma, sir. Sir, your comments.
Thank you. Thanks, sir, for your questions. So, firstly, this was a procedure which was chosen for fertility preservation. And as you asked that what is the data regarding preservation of fertility by UAE vis-a-vis by myomectomy? So there are no direct comparisons, only few papers are there, but they definitely show that the chances of fertility preservation are more with UAE as compared to myomectomy, especially with such large fibroids. The other important thing is about the cavity involvement, the involvement of cavity. So what I understand from the contemporary literature is that it is the involvement of the subendometrial junctional zone which is very important. And sir, as you can very nicely see in the MRI, as well as in the ultrasound, transvaginal ultrasound, the SMJ in the pre-procedure evaluation, the fibroid mapping MRI was involved. But later on, when the fibroid shrunk, the SMJ was seen nicely. So I think this is one definite and a very good role of UAE, that we can start by doing a UAE and then see if the SMJ is still involved. Then we can go for myomectomy, because then anyways it would be difficult to have a fertility. But if SMJ is not involved, then a choice may be made as whether a myomectomy needs to be done or whether a further setting of UAE needs to be done. And thirdly, we can also go in for further settings of UAE because it's a intramural fibroid. So if it becomes very small, as I mentioned in the chat also, the chances of fertility with a small of gestation with a very small fibroid may be acceptable, and also it would reduce the chances of the degeneration related complication during the pregnancy. So yes, it is, to begin with, it may be very well looked at as a bridging procedure, and then later on we can discuss with the patient and with the referring surgeon that what should be the future course, and as we plan in this patient also. Thank you.
So thank you, Professor Ashish, and thank you, Dr. Ishan. Thank you, Professor Ajay Khanna, sir. And now we are moving to second presentation. I request the moderator, Professor UP Shahi, sir, to initiate it. Over to you.
So welcome, thank you for. Today we have brought as you know, carcinoma of breast is almost equated with surgical removal of the breast. But now things have changed, and we are able to preserve the breast, and at the same time you can provide a radical radiation therapy, what we call, to preserve the breast and achieve the same outcome in carcinoma breast, particularly in early cases and selected cases. So here we are going to present a case of carcinoma breast who had been treated with primary radiotherapy. That means conservative breast surgery and then radiation involving interstitial brachytherapy and external beam radiotherapy as done in other cases. So I invite Dr. Nilesh, he's a senior resident in our department, to present the case. Thank you. Dr. Nilesh.
Good morning, respected teachers. Today for topic of clinical society meeting is brachytherapy in breast cancer. In previous clinical society meeting in 2021, we have presented the procedure of post-op brachytherapy in breast cancer. In this presentation, we are going to deal with the intra-interstitial implant. Coming to the case, a 56-year-old female resident of Varanasi, Uttar Pradesh, presented with chief complaint of lump in left breast for 2.5 months. On pre-op clinical examination, the lump was 4 into 4 centimeter in size in upper inner quadrant of left breast, which was hard in consistency with ill-defined margins, irregular surface, not fixed to skin and underlying structure. There was also a lymph node noted in the left axillary lymph node, which was found to be a 2 into 1 centimeter, which was palpable, mobile, non-tender, not fixed. Two-cut biopsy was advised on 13th/11 and was found to be infiltrated ductal carcinoma. On immunohistochemistry report, the estrogen receptor was positive, progesterone was negative, and HER2 receptor was 3+. On mammography, it suggests high density mass in upper inner quadrant, measuring approx 1.5 into 1.3 centimeter, and few prominent left axillary nodes are noted, partially covered on the mediolateral oblique view. Chest X-ray was within normal limit. Ultrasound suggests multiple gallbladder calculi with sludge. Bone scan was done. There was no evidence of bone mets. On ECG was normal. On echography, left ventricle ejection fraction was 60%. The stage was found to be clinically T2N1, group stage 2A. Patient was planned for breast conservative therapy, which includes breast conservative surgery plus radiotherapy. A word about radiotherapy. Radiotherapy consists external beam radiotherapy plus tumor bed boost. Tumor bed boost can be done by several techniques, of which interstitial brachytherapy is most conformal technique. When a patient is planned for intraoperative tumor catheter insertion, then the patient should be evaluated by both surgeons and radiation oncologists in a same OPD. The procedure of interstitial brachytherapy when done post-operatively. This is a case in which a post-operative implant was inserted, and in further slides, I'm going to tell about the intraoperative procedure. In intraoperative procedure, the patient was offered all the treatment, and she was informed consent was taken, and patient was planned for lumpectomy with axillary lymph node dissection on 7th of December 2021 under Unit A, General Surgery Department of IMS BHU, in which a curvilinear incision was given. The area is exposed and the tumor mass along with axillary lymph node dissection was done, and the boundaries were marked by the surgical clips. A total of 6 surgical clips were placed, and the specimen was labeled as specimen was labeled with the help of sutures, in which long sutures were given for the left borders and short sutures were given for the superior borders. And the patient and the specimen was sent for histopathological report. After which, this is a representative image of another patient. We could not take the video of the same patient of the clinical case. In this video, I am just going to explain the procedure, what is going to be done. In this, we can see that after incision, the tumor bed is directly visualized, and with the process of, this is the brachytherapy interstitial needle, which is being placed in the tumor bed. And the general principles of placing these interstitial brachytherapy needles is that, firstly, the central interstitial tube is placed, and remaining tubes are placed accordingly in different planes, and the distance between two planes should be 1 to 1.5 centimeter, and the distance between two needles should be 1 to 1.5 centimeter. Here we can see that in this case, 2 planes is being used, and the needles are then inserted accordingly. After insertion of these needles, the needles are removed, and this needles is being replaced by a plastic catheter, which is secured with one end by a button. Here in this diagram, you can see after removal of needles, the plastic catheters, in which the one end of the plastic catheter is sealed with the button and the other end is opened. Then the suture is closed, and this other end is also secured by the buttons. Then the patient is shifted to the surgical ward, and on post-op day 3, the patient is taken for CT simulation with catheters in situ, and the images of CT are transferred into the treatment planning system, where the target delineation is done. This is the image, the CT images which are transferred to the treatment planning system. The tumor target is drawn on each CT slide, and the plastic catheters are reconstructed. This is the axial, sagittal, and coronal view, showing the red area is showing the tumor target area, and these red dots are showing the catheters. This is a 3D reconstructed image of catheter with target volume. The main concept is that our target volume should be adequately covered with the 100% of prescribed dose. In this diagram, one can see the different isodose lines, which represents a specific percentage. The different isodose lines are represented by a different colors. The main purpose is behind is that the skin should not receive more than 95% of prescribed dose. Otherwise, it will lead to increased skin toxicity like mucositis. And the distance and the two adjacent needles, we should try to keep in mind that the 150% isodose line should not be connected to each other as minimum as possible. Here you can see, this is the 3D reconstructed image in which we can see the placement of the interstitial catheters, and this is the inside view. Where we can see the our target is adequately covered. The main thing to delineate the target is that it should cover the tumor bed along with any post-op changes and post-op cavity. We also take the help of surgical clips, and it should be taken into account. After this, the patient is transferred to our brachytherapy bunker, in which this is our SDR unit, which has a iridium 192 source. It has a multiple channels. A total of 30 channels is present in this, and these plastic catheters are connected to this machine with the help of a transfer tube. One end of transfer tube is connected to the plastic catheter, and the other end is transferred to connected to the brachytherapy unit. And then by after remote loading technique, the source traverses each of these channels and reaches to the tumor bed and imparts its doses. On brachytherapy, dose delivery is delivered on third and post-operative day, and it is delivered in 3 settings. On third post-operative day, 2 doses of 4 gray each, 6 hours apart is delivered. On fourth post-operative day, 1 dose of 4 gray was delivered. Plastic catheters are removed after third brachytherapy dose by us, and the patient can be discharged on fourth post-op day after completion of brachytherapy. After this, we ask the patient to review after 10 to 14 days with complete histopathological report and with surgical removal of the clips, and after surgical removal of and complete wound healing, we take the patient for external beam radiotherapy. In histopathological report came on 31st December 2021. The tumor type was invasive ductal carcinoma grade 1. Tumor size was 1.3 into 1.3 into 1 centimeter. Extent was unifocal. LVI PNI was negative. No extensive in SUDI component. Margin was free. Distance from closest margin was 3.5 centimeter. And a total of 17 lymph nodes were removed, 10 from axilla and 7 from apical group. Pathological staging comes to around T190 stage 1, AJCC 8 classification. Then this patient has been treated with external beam radiotherapy to whole breast with 6 MB photon on linear accelerator. An ultra hypofractionation schedule was used, which is 26 gray in 5 fraction, 1 fraction daily, and the total treatment was completed within 1 week. This is our linear accelerator machine, which is this is our gantry, this is the treatment head. This can rotate in clockwise and anti-clockwise direction. Patient is made to lie supine over the couch on a breastboard, and it is immobilized with the help of thermoplastic cast, and whole breast is treated with T2 tangential fields. After completion of EBRT, patient tolerated radiotherapy well, and she was planned for adjuvant chemotherapy of 3 cycles of 5 FEC, 3 weekly, followed by 3 cycles of paclitaxel. Patient has received 2 cycles and is due for 3rd cycle of chemotherapy next week, and it will followed by adjuvant hormonal treatment and trastuzumab. Coming to rationales for using 1 week therapy.
Summarize.
This is Barent et al. Has compared 26 gray in 5 fraction daily, 27 gray in 5 fraction daily, and 40 gray in 5 fraction, 15 fraction, compared with the standard 40 gray in 15 fraction, and it has found that 26 gray in 5 fraction is non-inferior to 40 gray in 15 fraction for local tumor control, and it is safe in terms of normal tissue effects up to 5 years. And the rationale for giving boost or no boost whole breast irradiation with or without boost for a patient treated with breast conserving surgery for early breast cancer, a 20-year follow-up of a randomized phase 3 trial published by Bartalik et al. In 2014 in Lancet Oncology suggests that ipsilateral breast tumor recurrences was 16.4% in non-boost group versus 12% in the boost group. At last, advantages of brachytherapy. It is the most conformal technique. There is a sharp dose follow-up, decreased toxicity to organ at risk like ribs, lungs, and heart. Flexible to conform the complex geometry, tumor bed geometry. And prerequisite for brachytherapy are the disease should be at the accessible site. It should be well localized. The disease size should be relatively small. as compared to the breast. A high clinical expertise is required, and it needs clinical and radiological localization of the disease. Comparing intra-op with post-op, in intra-op, there is accurate tumor bed visualization, so there is very less chance of tumor bed boost, and there is total reduction in overall treatment time. We can avoid second intervention and second anesthesia because both the settings are done in same sitting, and patient compliance. Cons are lack of margin status due to unavailability of progesterone section in our department. For post-op settings, complete histopathological features are available, so we can plan accordingly. And the pros of intra-op are the cons of post-op. Take-home message is, in breast conservative therapy is the standard of care in early breast cancer, and intra-op is the best modality of tumor bed boost. It merits multidisciplinary approach. Thank you.
Thank you, Dr. Nilesh. Now, am I audible?
Yes, sir, you're audible.
Yes. So this is a presentation. Here's a case to show that how the two departments, surgery and radiation oncology, together can really redefine the best care of carcinoma breast. As I told, breast mastectomy is one important factor which prohibits female to come to the clinics for the treatment, because, as you know, breast really constitutes or is a very important part of self-image, and nobody wants to. Our female patients don't want to lose that. So, providing an alternative treatment where surgical removal is avoided, and by using a conservative surgery and radiotherapy, a similar outcome is provided. The purpose of presenting this, as I told you, what we have done separately, in fact, it is a part of our thesis being undertaken in our department. And what we have done, we have given brachytherapy intraoperatively. Intraoperatively means in the OT room, radiation oncologist also present there. And as you saw the video, we can put the needles into the at the tumor bed by fully knowing where was the tumor and how much to cover. So it provides a best opportunity to take care of the tumor bed and provide the dose as required. So this was the advantage of this intraoperative. Alternative to that, we can give brachytherapy even after surgical closure of the tumor after the surgery. Later on, maybe after 2 to 3 weeks. That is one thing. So both of the things are being done here, and this is for intraoperative. So considering this, as we have not shown you the final outcome. Okay.
I think
That's so.
Professor UP Shahi, sir, can we have the comments from the surgical oncologist also?
Yes, we will certainly. We have invited.
Have you invited? Have you invited any surgical oncologist for this presentation?
Yes.
Okay.
Dr. Sanjay. Huh?
Okay. I request a consultant from surgical oncology and general surgery. They can unmute and give their comments.
Okay. Welcome. So before that, that was the purpose. We should show that. Now,
okay. Now you can unmute yourself. Anyone, Department of General Surgery, or
can I respond?
Yeah,
Dr.
good morning
Abhishek?
all. Abhishek,
yes.
you are able to hear me?
Yes, Dr. Sanjay, I am able to hear you.
Yeah, good morning to all. Yeah, thanks to Department of Radiotherapy. They have started a good thing towards the conservation and good towards the minimal intervention. And it's a really great pleasure for a woman who is having the breast cancer and preserving her breast without giving so much pain, without so much the pain for the cosmetics. Yeah, actually this patient was operated in our unit, and we planned this patient for the breast conservation surgery, and it was a good case to take up, and patient was thoroughly counseled and patient was well educated, and she understand the value of breast conservation surgery. So we planned accordingly, and patient was successfully given radiotherapy. Now she is doing good, she is in close follow-up, and so far we have done more than 10 cases of the BCS in collaboration with the radiotherapy, and those all patients are there doing fine and they're very happy.
Okay. Thank you, Dr. Sanjay Sarosh. I
Yeah.
request Professor Sanjeev Gupta, sir. Sir, you can unmute.
Thank you, Abhishek. We have been many years now because of the lack of.
Sir, I think your voice is not audible. There is some issues there. We are not able to hear you properly.
Can you hear me now?
Yes, sir. Now you're audible.
So what I'm saying is that breast conserving therapy needs a surgeon and the radiotherapist, and that has to be done pre-operatively so that all of us are on the same page. Radiotherapy is an essential adjunct of breast conserving surgery, and what is done is that the surgical component is a must. You cannot have breast conserving surgery without surgical excision, and axillary lymph node status has to be determined at the time of the initial surgery, either by a sentence, and obviously there is a limited group of patients who are amenable to breast conserving surgery and the radiotherapy the way Dr. Shahi's team has described. And it is a good thing that brachytherapy ke jo sabse bade advantages hain, it is that the collateral damage is very less. It can give a focused radiotherapy to a small area without affecting the other sites. And in fact, recently we had a patient who had a bilateral breast cancer, and on one side we did a mastectomy, on the other side we did a wide local excision, which was at the same time intraoperatively the radiotherapy team with Dr. Sunil Chaudhary came and put the needles, and then they gave her brachytherapy. So the problem is that we don't have MDT teams in the institute. Unfortunately, it has never happened the way it should be, and that is something which we need to focus upon to have MDT. It is more of an individual collaboration on an individual basis rather than a formal MDT team. So that's what I have to say. Thank you very much.
Thank you, sir. So what's the problem, sir? Why we do not have such a team? Professor UP Sai, sir.
In fact, we have been in this process, and previously also we had a joint clinic with surgery departments. Thing is, even our surgical oncology is overburdened, but there is a need to form different specialty groups which can undertake various cases on their merit or on the line of the clinical research and advancement. So this is very much required to have joint clinic and specialty clinic to undertake various cancer groups. This is very important, and this has to be done. We are in a process. We are inviting our colleagues from different departments to form such a special groups, and we are hopeful. We are hopeful that we'll be able to make such groups.
And I think if the inputs from the surgical oncology department were also there in this presentation, that would be added
Yes.
advantage. That was lacking here. So
Professor Dr. Sanjay has already given his input because
yes, sir. We have the inputs from the general surgery department. I am asking that if the surgical oncologist people were also there, so that would be added.
Abhishek?
Yes, sir. Yes, Dr. Sarosh.
Sanjeev Gupta sir has rightly told regarding the multidisciplinary team, because it's not a work of a single person. It requires the multiple disciplinary team approach, where it's a more important apart from doing the surgery and doing the radiotherapy, patient needs to thoroughly counsel, and patient should be closely followed. We have two residents, they are in close follow-up. They regularly contact the patients, and we sit on Friday. Every Friday, we from the surgical department, our whole team and the radiotherapy unit, we sit together and discuss all the possible treatment possible for all the malignancy what we are encountering our units.
Okay, thank you.
That's regularly we are doing. Professor Shahi is also a active member of that team. Regularly we are doing, and that's giving good result. Patients are very happy.
Good. I request Professor G.N. Srivastava, sir, please unmute and ask your question.
Yeah, thank you, Dr. Abhishek. My question is very common after radiation therapy in the department, especially at the area what he is discussing. We face a lot of problem with the pneumonitis, post-radiation pneumonitis, pleural effusion. Usually their manifestation is less. So with this therapy, is it minimum?
Yes, yes. In fact, this radiation pneumonitis many times is associated with external beam radiotherapy. But when
I'm audible?
external beam radiotherapy.
Yes, sir.
Yes,
you're audible, and your questions, Professor Shahi sir is answering.
Okay, sir. Thank you.
So that is one issue, but with brachytherapy, this problem is almost nil. One thing that is there.
Sir,
Yes.
sorry to interrupt you here. I think the senior resident who presented this case, can you tell me the numbers? What is the incidence of post-therapy pneumonitis, post-radiotherapy pneumonitis? I think saying the minimal or very few will not work. How much percentage?
5 to 10 acute pneumonitis is occurred in very less cases, or around 5 to 10%.
5 to 10% of the cases. How it can be minimized?
It can be minimized. It mainly depends upon the patient geometry. So in tangential field, if a larger amount of lung tissue is irradiated, then only it can represent. But in our settings, we have very few cases and very few cases of radiation pneumonitis, which usually managed by a antibiotic coverage of one week.
As such, we are really practicing a minimum complications. But the thing is, the field we plan in carcinoma breast, that involves irradiation of the part of the lung also. So that's give this complication of pneumonitis. But however, in a large number of percentage, they are well managed. That is the thing.
Okay, thank you.
Okay.
Thank you, Dr. Shahi.
Okay, thank you, sir. Another thing I want to tell you, even with surgical oncologist team, we have formed a team and we have a thesis on this breast only, where we use post-operative brachytherapy. And that has also shown a very good results. But here, since we are intraoperative, so that's why we presented this. Thank you.
Okay. I request Honorable Dean Research, Professor Ashok Chaudhary, sir, to give his comments.
Good morning. This was really nice presentation from both the departments. Regarding the first, in the radiology department, the resident mentioned of the conscious sedation, and I'm a little bit concerned that who monitored the patient, because as we do interventional procedures, which is a good thing, these are being done in BHU, but the patients require regular monitoring. So I understand that the best person would be an anesthetist who will come to interventional radiology and do the monitoring. And there should also be space for keeping these patients post-intervention so that they can be looked after by the clinical team as well as by the interventional radiologists. So that was my comment. Otherwise, wonderful job they have done. Regarding radiotherapy, again, very interesting case. And they have done good work that where the organ can be preserved. The lack of MDT, I understand it is also known as the tumor board. So what prevents us from having a MDT? We have our patients, we have our radiotherapy experts, we have general surgeons as well as the surgical oncologists. So there is no reason why there should not be MDT. Or do we require a chitti from development section or assistant registrar that we establish MDT? So, Dr. Shahi, I think that the department which are taking the major decision making in MDT or tumor board, those consultants should take initiative, and it's better late than never, I think, and we start doing it. I mean,
Thank you.
otherwise, in
Thank
next
you,
year
Dr.
clinical
Ashok.
meeting again, we will hear that there is no MDT team and those kind of things.
Yes,
So
sir.
it
For
should be
last
taken
two,
seriously.
sir, for last 2-3 times I have heard this thing that this
Yes.
team is
So I
not.
think either radiotherapy takes initiative or surgical oncology or the general surgeons who are interested in oncology patients. They should take initiative.
I take the.
I request Honorable Dean Professor S.K. Singh sir to give his final comments.
Good morning. Thank you, Abhishek. The first case presentation by Department of Radiology, intervention radiology. This is evolving very fast, and that we have witnessed. I think they have done a commendable job, and of course, it is a new kind of therapy given to our patients. But we may not have the RCT for the success of this therapy, but still, as we evolve, definitely will find that it is superior to the existing method of treatment. So I'm that much optimistic, and this should be carried on. Regarding the second case, Dr. Shahi's team has also done a wonder job. And the one thing that has come up is the tumor board. And we have been talking about tumor board. And I remember there is a tumor board by pediatric hematology unit. Dr. Vinita Gupta already has made it. Similarly, a tumor board can also be made, and MDT can be in place at our institute. This is what we expect. So Dr. Shahi will take over, I'm sure, and he will be helped by his colleagues to have a tumor board from now. So congratulations to both the department, and thank you very much.
So thank you, sir, for your comments, and thank you everyone for joining this clinical society meeting, and happy Holi, and see you at the next clinical society meeting. I close this meeting now.
Happy Holi.